Hello, I'm Larry Phillips, Director of Nuclear Cardiology at NYU Langone Health, here to discuss a case for Refer Wisely. This is a case of a 63-year-old man undergoing evaluation after an abnormal screening test. It's a 63-year-old man without past medical history who was seen by his internist after being found to have an increased coronary artery calcium on a screening test. His office had offered a free screening test, which consisted of electron beam tomography of the heart. He was told that his calcium score was read at 434.8, with calcification noted in the left anterior descending, the left circumflex, and the right coronary arteries. He denied any prior chest pain or shortness of breath, and in fact states that he's physically active, jogging 5 times per week. As mentioned, he denies any prior history, including any prior cardiac history. He was not taking any medications at the time of visit, and his family history was significant for diabetes in both of his parents. His physical exam showed normal tension with a normal heart rate, and no physical exam findings suggestive of underlying disease. Here you can see his baseline EKG, which shows normal sinus rhythm in 60 beats per minute, with a normal axis and intervals, and no significant ST or T-wave abnormalities, no ST segment deviation, either depression or elevation. So the question at this time is, if you see this patient into your office, what would be your next step? Option 1 is initiate guideline-directed medical therapy without further diagnostic testing. Option 2, initiate guideline-directed medical therapy with functional assessment by treadmill stress testing. Option 3 is initial guideline-directed medical therapy with functional assessment by treadmill stress testing with the addition of cardiac imaging to determine ischemic burden. Or option 4 is initiate guideline-directed medical therapy and evaluation for ischemia with pharmacologic stress testing. So when determining the patient's risk, it's helpful often to use a risk score. And here you can see an example of the MESA 10-year risk score. And it's a risk score that incorporates several factors that the patient has, including gender, age, race and ethnicity, prior risk factors including diabetes, smoking, and family history, lab results including cholesterol, vital signs including blood pressure, and prior medication use. And it also incorporates coronary calcification, showing us, as you can see where the arrow points, that the patient's 10-year risk of an event is 11.3% compared to a risk without any coronary artery calcification being incorporated at 5.6%. This is based on large databases of patients and ability to predict event rates utilizing this resource. So we can see that this particular patient we talked about, by plugging in all the data we have, has an estimated 10-year risk of 11.3%, putting them at a high risk. So what about guideline-directed medical therapy and the question of using cholesterol medication or statin therapy? So in the 2013 American College of Cardiology, American Heart Association blood cholesterol guidelines, they outline a set of patients for primary prevention of utilization of statin therapy. And these are patients without diabetes and with an LDL less than 190. And you can see here, based on the options below, specifically under C Part 1, that a patient with a 10-year risk greater than 7.5% should be started on moderate or high-intensity statins. Under option 3, you can see that independent of that risk of 7.5% or greater, that those with an AGSIN score of greater than 300, similar to our patient, may benefit with a 2B indication starting statin therapy. What other medication would fall under guideline-directed medical therapy for this patient population? Well, aspirin would be one. So here you can see a study which looked at the risk of patients and then subsequently the number needed to treat to see a reduction in events for patients with different levels of coronary artery calcification. And if you look at the third section on the right, you can see those with coronary artery calcification greater than 100 Agatston units had a very low number needed to treat, independent of what their pre-test likelihood was for a 10-year event rate. Now, how about functional assessment and imaging? The multimodality appropriate use criteria give us guidance. So here, published in the Journal of Nuclear Cardiology in 2014, are multimodality appropriate use criteria. which shows us based on different imaging modalities and testing modalities in our armamentarium what the appropriateness level would be. And the definitions would be that a test falls into an appropriate category, a maybe appropriate category, or rarely appropriate, and using these definitions to allow autonomy for the physician based on the clinical practice. And here we can see a patient with an Agassiz score of greater than 400. Appropriate category is exercise ECG, and in the maybe appropriate category are the other imaging modalities, so stress SPECT imaging, stress echocardiography, and stress CMR. Of note, the options that we gave earlier for what to proceed with this test, we did give a pharmacologic test option, but we'd encourage patients who are able to exercise to use exercise as the modality of their stress when they're undergoing an imaging test, because it gives additional information besides the imaging alone. So in this particular patient, he was sent for an exercise nuclear stress test, but we're going to spend some time talking about the exercise component first. So the patient walked on a treadmill using the standard Bruce protocol, where the heart rate is watched to reach 85% of maximum predicted heart rate as the minimum amount of a threshold. But we're watching as every 3 minutes the treadmill speed and incline increases, watching the heart rate response, the blood pressure response, and the EKG. And here we can see the patient was able to exercise for a high intensity at 13 minutes and 28 seconds, reaching a peak heart rate of 169 beats per minute, and a notable hypertensive response at 232/90, but with no symptoms. Remember, this is a patient that jogged 5 times a week. Here you can see the baseline EKG for this patient, which shows normal sinus rhythm without ST segment deviation, similar to the EKG we saw in the office. But at peak exercise, we can see several changes, specifically in the inferior leads 2, 3 AVF in the lower left-hand corner. You can see horizontal to downsloping 2 millimeter ST depressions. In the anterolateral leads, specifically in V5 and V6, you can see again ST depression, specifically in V6 of 2 millimeters, using a diagnostic threshold of 1 millimeter of ST depressions, either horizontal or downsloping, to show an abnormal test. So the patient had excellent exercise capacity, reaching stage 5 of the Bruce protocol and exercising for 13.5 minutes. No symptoms of chest pain, but 2 millimeter horizontal ST depressions, with a normal hemodynamic response in that the heart rate and blood pressure were increasing, but as noted, the blood pressure reached a high peak level. One way to determine risk is to use the Duke Treadmill score, and the Duke Treadmill score incorporates 3 components into the reading: the number of minutes the patient is able to exercise, the chest pain presence, absence, and severity, as well as the ST segment deviation. And here I give a calculation showing that the patient exercised for 13.5 minutes, that they did not have chest pain, which is a 0, and that they had 2 millimeters ST depressions. And when you calculate it together, it reaches a Duke Treadmill score of 3.5, which puts the patient at intermediate risk. Now, had the patient undergone a treadmill stress test alone, then subsequent testing with imaging could be warranted. But in this patient, we already have the information for their perfusion imaging. And here I show myocardial perfusion imaging for this patient, and there are 3 sets of images. So the first 3 lines are the short axis, the next 3 lines are the vertical long axis, and the third 3 lines are the horizontal long axis. And the way these are set up are ways to look at the heart in different angles, looking at the left ventricle and the 17 segments. So I'll go forward for a second and say that the raw rotating data showed that there was increased gut uptake on both the rest and stress, which makes looking at the inferior wall, the bottom part of the heart, a little more difficult. When gating and looking at the squeezing function of the heart, both the rest and post-stress showed normal ejection fraction, and there were no evidence of high-risk features, including transient ischemic dilatation. Going back to the perfusion images, we can see that the stress images, the top lines of each of the 3 segments, versus the rest images, the third line of each 3 segments, are similar, showing fixed inferior wall deficits, which, given the gut that was noted on the raw data and the normal wall motion, is consistent with attenuation. overall being a normal perfusion scan. Now going forward 2 slides, a summary of the findings. We see that the patient had no symptoms with exercise. They had excellent exercise tolerance for age and gender. They had EKG changes which were suggestive of ischemia, but when looking at higher sensitivity and specificity imaging with myocardial perfusion imaging, we saw no stress-induced myocardial ischemia on the perfusion images, and the ejection fraction was normal. So how did we deal with this patient? Well, first, at this point, with a normal myocardial perfusion imaging, we decided no additional diagnostic tests needed to be performed. A low-dose aspirin was initiated based on the data shown earlier, and high-dose statin therapy with atorvastatin 80 milligrams daily was started, again based on guidelines discussed earlier. Bringing all this together, it's important to know that increased coronary artery calcium does suggest a higher cardiovascular risk, and that there's certain goal-directed medical therapy that can decrease the risk of subsequent cardiac events in patients with this elevated risk. The benefit of adding perfusion imaging in asymptomatic patients with elevated calcium score requires further investigation, and that's why it has the maybe appropriate indication under the appropriate use criteria. But testing with treadmill testing alone has been shown to help in risk modification or determination. Thank you.
Hello, my name is Dr. Gretchen Diemer, and I'm an Associate Professor of Internal Medicine at Thomas Jefferson University in Philadelphia. I found this case challenging to comb through from a high value and appropriate use point of view. My first question was, why would a calcium score be ordered? I realize we are given the case when that has already happened through a free screening at work, but I think it is worth thinking about when that might be a valuable test. Different risk calculators yielded different levels of risk for this individual, but here we used the MESA, which predicted a 5.6% 10-year risk without using the calcium score. And as we saw, the 2013 ACC-AHA guidelines suggested that at a risk above 5%, a statin could be considered at that level. So we could have just stopped and used that score and given this patient a statin and still been within the guidelines. The USPSTF sets a minimum risk of 7.5% for a patient before considering statin therapy. So the calcium score might be useful in a patient like this that are, quote, borderline in terms of having different guidelines applied with different results. Using the calcium score increased his calculated risk to 11.3%, which is an indication for moderate to high-intensity statins in many of the guidelines. So we have the score now, and it came back high. And the question arises, does he need additional workup to inform our management decisions? Using the appropriate use criteria chart for the abnormal calcium scores, it says that nuclear stress tests with perfusion imaging may be appropriate. Given that he has excellent functional status and statins are already indicated, I wondered what the stress test really contributes to my management of this patient. The appropriate use criteria are much easier to interpret, I think, when they suggest either that the test in question is appropriate or is rarely appropriate. Those circumstances are a little easier to figure out what to do. When the result falls into the maybe appropriate column, you need to think carefully about how the test results will or will not affect your management, and only proceed with the test if you believe it brings value to your patient or specifically helps you to answer a management question. I'm not clear in this case that the perfusion imaging helped me answer a question pertinent to the management of this case. As Dr. Phillips described, the result of the test was intermediate risk, and the patient was started on a high-intensity statin for primary prevention, which was already recommended by the guidelines. I believe if the result had been low risk, I still would have begun the statin. Dr. Phillips, could you comment on how alternate perfusion imaging results might have changed your management of this patient?
Yes, I think that with higher ischemic burdens, so if you start seeing a larger amount of abnormality on the perfusion, you're going to go in the direction of being more aggressive. In this patient with calcium in multiple coronary arteries, your concern is that you're going to see a patient who actually has high-risk findings. So either in the perfusion showing marked abnormalities with reversible defects suggesting ischemia, or other high-risk findings either in the ejection fraction or in the TID ratio. Any of these might push you to wanting to then anatomically look at possible revascularization. But because there's still debate in the medical community as far as which findings would require revascularization, it puts it in that solid maybe category. In addition, if multiple areas of myocardial perfusion abnormality are seen, you're likely to start other pharmacologic therapy as part of your guideline-directed medical therapy, and that include incorporation of ACE inhibitors or beta blockers into the patient's regimen.
Excellent. Thank you.